Yes, sir.
Yeah. So I'm not adding very much more than what you have said, but just for the sake of visual impact, so that remembrance will be much easier. So video laryngoscope utilizes the video camera technology to visualize airway structures and facilitate endotracheal intubation. So whereas your conventional laryngoscope, which is called the direct laryngoscope, where the bulb emits a light and you are looking directly into that. Whereas here it is a video camera which picks up the structures inside the mouth up to the glottic opening and then projected onto a screen. So you don't have to all the time be looking into the pharynx and throat of the patient. So the advantages of this are it uses the indirect laryngoscopy via its camera. That is the first and foremost difference between what we have been all these years trained conventional Macintosh laryngoscopy, thereby eliminating the need for a direct line of vision to visualize the airway structures. This is the first advantage of that. You don't have to bend and look into the throat. And video laryngoscopy requires the application of less force, that is only 5 to 14 newtons on the base of the tongue, therefore causes less stress response and less local tissue injury. This is supposed to be the second advantage. The third one is certain video laryngoscope need very limited cervical movement. Unlike your Macintosh laryngoscopy, direct laryngoscopy, where you have to put the patient in the sniffing position with the flexion of the cervical spine and the extension at the atlanto-occipital joint, this is not required. You can do it without much of a disruption, especially in cases of cervical injury. And if you are already trained with your conventional direct laryngoscopy, you can learn video laryngoscopy much more easily. The learning curve is very short time. And it's an effective tool for those who infrequently intubate as well as students learning to intubate. And possible awake assessment and intubation is easily done under topical anesthesia. So all the time you need not induce the patient and paralyze and all that, and can provide an official record. This can be used as a pre-op assessment, especially if you are going to do a thyroid surgery and you want to see the vocal cord movements. All these years we have been sending them to ENT surgeon for an indirect laryngoscopy with a mirror, or nowadays nasoendoscopy is also being practiced. But video laryngoscope gives a good opportunity for you to spray the tongue and then pharynx and introduce the video scope and have a look at the vocal cords, and even you can document it by taking a photo, and the official record can be maintained. The disadvantages are sometimes you have difficulty in passing the ET tube and good visualization, especially if the blade is more angulated. There are different types of blade, conventional Macintosh and then angulated, hyperangulated. So there is a classification on the shape of the blade itself. So the angulated blade sometimes causes difficulty in visualization, and it may cause increased intubation time, especially when you are a beginner. And a direct laryngoscopy still may be lost if you when this comes into a regular practice. People will forget how to do a direct laryngoscopy using conventional Macintosh laryngoscope, which sometimes may be difficult because you may not get this video laryngoscope in all the places at present time. So one has to be aware that they have to use the regular Macintosh laryngoscope, and direct laryngoscopy also should be learned. And it, it may give you a false sense of security that you can manage any difficult airway if you have a video laryngoscope, but that is not the true truth all the time. So lack of preparation may land you up in a problem with a difficult airway, and it's only a two-dimensional view with loss of depth of perception. And as he mentioned, it may be skewed by fogging and secretions on the camera lens. Nowadays, they have camera tips which are fog resistance with an anti-fogging coating that is applied to that, so that will not get fogged. That has been taken care of. and it may be more complicated and expensive. So these are the disadvantages of DVD laryngoscope. Now, this is what your conventional Macintosh laryngoscope. In the mannequin, what you see, you are put, this is, all of you are used to this. So you place the laryngoscope in the oral cavity and see the person is bending to look into the throat. On the contrary, a person who is doing the video laryngoscopy, you can see he has already passed the scope and he is trying to visualize it in the monitor. So there is no direct line of eye contact is required. These are the various types of blades that are used with laryngoscope and the angulations that are made, and the differences in this, what happens in the Macintosh laryngoscope where you have the conventional, the angle is only at 15 degrees. Whereas in the Macintosh type of video laryngoscope, you have a larger angle, 40 degrees. And in the angulated blade, the degree is 60 degrees. So this point is sometimes asked in the oral examination, what are all the various angles of vision in these various instruments. So 15 degrees for Macintosh, 40 degrees for regular Macintosh video laryngoscope, and 60 degrees for angulated video laryngoscope. And you have the video laryngoscope blades which are channeled and non-channeled. So the picture A shows a video laryngoscope which is a removable blade which is attached to the handle, where there is no channel for the endotracheal tube. So you have to pass it separately after you visualize the glottis. Whereas the other channeled blades have got a provision to insert the tube as you are using the blade itself. And then once you visualize the glottic opening, you can just push the tube along with that without the need for introducing it separately. And this is how the two tubes are. This is the unchanneled blade which is being used, and the person is trying to introduce the tube separately. Whereas if you have the channel, you have to hold it together with the handle so that you can visualize and then push the tube inside. There are two curves in the, this is what I told you about the not a always a requirement to position the head and neck. So there are two curves. One is called the primary curve, which involves the oral cavity to the glottic opening. Then there is a secondary curve starting from the vocal cord, that is laryngeal inlet to the trachea. So these two have to be manipulated, and you have to uh, adjust the tube. So this angulation here, this is what is going to cause a little bit of problem in introducing the tube into the larynx when you use the video laryngoscopy. Whereas when you do your conventional scopy, you are aligning everything together, the oral axis, pharyngeal axis, and laryngeal axis or laryngeal axis, and you are able to pass the tube directly. Whereas here the curvature is preserved, the primary curve and the secondary curves are preserved. So you may need a stillet or a bougie, or you may need to rotate the tube to introduce it into the larynx. So this picture will tell you why that difficulty occurs. And what are the non-operating room or off-site use of this particular instrument? Is patients requiring endotracheal intubation in a non-operating room settings like emergency department or ICU or pre-hospital are typically associated with hemodynamic compromise. So in that situation, as I told earlier, because this instrument produces less stimulation of the sympathetic nervous system, this will be a more ideal way of intubation rather than your conventional Macintosh laryngoscopy. And these patients often are ASA 3 or 4 category and have much higher risk of difficult laryngoscopy and intubation even when operator has adequate airway skills. All of you would have experienced this when in an emergency situation is a patient struggling with an aspiration or partial head injury who is the GCS 7 or 8. still having some reflexes, you may find it difficult to intubate. In all these situations, video laryngoscope may be much more helpful. And increased first attempt success and decreased time of intubation with glide scope has been recorded in these cases. And in patients who are obese, with morbid obesity of BMI more than 40 kg per meter square are commonly associated with difficult intubation. So all video laryngoscope devices offer equivalent or improved glottic views in these patients, and better overall satisfaction score, intubation time, number of intubation attempts, and necessary extra adjuncts are all been recorded. So in obesity also, this is a very useful instrument as a substitute for fiber optic bronchoscopy, which may not be available in all the areas. An anticipated difficult airway of a morbidly obese patient, many video laryngoscopes have been used in topicalized patients undergoing awake intubation. So, in a morbid obese patient with an anticipated difficult airway, it is always safe to go for an awake intubation under topical anesthesia. And for that, more than the Macintosh, the video laryngoscope is a very useful instrument instead of using the bronchoscopy. And for teaching, video laryngoscope can serve as a teaching and supervising tool for tracheal intubation with real-time displays during laryngoscopy. It also allows for viewing and magnification of the airway anatomy and associated anomalies, especially if there are some congenital anomalies like webbing or displacement or sometimes arytenoid fractures. All this can be easily displayed on the monitor for the students to see. And instructors can provide feedback for novice laryngoscopists to overcome difficulties related to direct laryngoscopy and tube insertion, and may also help with airway manipulations. Other applications are awake intubating VLscopy not only has application in obese patients but can be used in difficult airway situations warranting an awake intubation or instruction. Due to decreased amount of pressure applied to the base of tongue, topicalized awake patients can tolerate video laryngoscopy better than your conventional laryngoscopy. And exchange of endotracheal tube over a gum elastic bougie or a Cook's catheter can be performed in a critically ill patient whom you have intubated with the difficulty in the first attempt. So never just like that remove the tube. If you had difficulty in passing the tube, always leave a tube exchanger or a gum elastic bougie or a Cook's catheter, so that anytime you can re-intubate those patients. The other applications of VLscopy include foreign body removal from hypopharynx, which he mentioned, intubating in the setting of epiglottitis, which is a very common thing in pediatric age group. Placement of double lumen tube also can be done better with video laryngoscope, and percutaneous tracheostomy also can be done with the help of video laryngoscope. The limitations and complications, despite improved glottic view, ET tube insertion sometimes may be problematic, especially with angulated blade, as I told you, because of the primary and secondary curve. And a number of complications have been reported. Damage to the soft palate, palatopharyngeal arch, palatoglossal arch have all been seen with video laryngoscope, especially in the learning time when you are very rough in introducing the scope without, you have to be very gentle with that. Now, some explanations may be because of rigid spillet or blades are too large. These are all the reasons. So you have to choose the correct size blade, and blind advancement of the spillet or the EV tube may be the other cause for damaging the soft tubes. Another possibility is the operator placing all their attention on the monitor and blindly attempting to insert the tube without seeing the oral cavity. So for this reason, they have introduced a procedure called mouth screen technique, which he described as step 1, step 2. So first step is look into the mouth as you insert the video laryngoscope to avoid oropharyngeal trauma. Second, immediately after gently introducing the video laryngoscope to some distance, shift your head and look at the screen. to visualize whether you are seeing the epiglottis. That is the first structure you have to identify. Then again look into the mouth. After you visualize the epiglottis in the monitor or the screen, look into the mouth as you insert the endotracheal tube into the mouth to avoid oropharyngeal trauma. Then as the tube tip is seen at the screen, you just start adjusting it and try to pass through the larynx. So these four steps have to be correctly followed: mouth, screen. And the four key technical skills are epiglottoscopy in suctioning. So as soon as you see the epiglottis, if there are any secretions, you cut them out with a Yanker suction. So use video laryngoscope to protract the floor of mouth and mandible forward with minimal force, and use the anchor suction to remove all the secretions so that the videoscope tip is not covered by the pool of secretions. The second step, use the anchor suction to drain the fluids and retract to lift the epiglottis off the posterior pharyngeal wall. So this is the first step of technique. The second step is lifting and expanding the view. So additional jaw distraction, that is you have to pull the mandible forward and epiglottis in a controlled fashion with significant force so that you can open the hypopharynx and maximizing the laryngeal exposure, which increases the space for tube delivery. The third step is tilting the optics towards the endotracheal tube. And if the imaging lens of the hyperangulated device is tilted too close to the target, there is no space for tube delivery. This is the primary difficulty everyone will have in the initial phases. So hyperangulated tube, you must make sure that you create adequate space for the tube delivery. And sometimes with the hyperangulated blade, you may not see the tip of the tube at all if you have not sufficiently lifted the tongue. The imaging lens of hyperangulated devices look upward toward the larynx, but the trachea follows the cervical thoracic spine diving posteriorly. So this is the junction where you may have difficulty. By tilting the imaging towards the ET tube, this angle difference is lessened, making it easier to drive the tip into the larynx. So when you are using a hyperangulated blade, make sure that you are able to visualize the tip of the endotracheal tube all the time. And then two-stage tube delivery. This is the last step in the technique. Advance the tube slowly until the tip comes into view. Then adjust your insertion angle and direction as needed to get the second stage of the tube delivery, that is introduction into the larynx. If using hyperangulated fillet, then use what is called the stop, pop, and drop method. What do you mean by that? Stop fillet insertion after the tip is through the cords, then pop the fillet out of the tube, that is pull the fillet back, and then drop the now partially non-filleted tip into the trachea. So first step is to go into the larynx, stop the fillet advancing beyond the tube, pull the fillet out, second step, pop, and then push the unstillated tip of the tube into the trachea. So this is the technique that we have to follow. And another option is to rotate, and you can do as we all sometimes do when the tip is reaching against the angulation of the vocal cords. We always try to turn the bevel downwards and then push it into the trachea. So that also can be done. And following intubation, remove the stellate, especially in the hyperangulated endotracheal tube, in a caudal direction towards the foot of the bed. That is, you have to pull it down like this, not to straight like that. Then you may pull the tube also out. So always remove the stellate in a fashion where it is pulled towards the foot of the patient. And the too many mentioned so many names which are all difficult to remember in the examination time. So the video laryngoscopes classified into Macintosh blade type, angulated blade type, and channeled rigid type. This is one classification. These are all the examples of the various makes or the designs. And the other classification is integrated channel laryngoscopes, video stylets, and rigid blade laryngoscopes. So these are all the examples of such marketed available brands. So you can use this classification or combine all these together and have a single classification of they are classified into according to the shape of the blade or whether they are channeled or not channeled. So that is the major classification that we have to write, and so that will give you an idea, I think, about the answer you have to write for video laryngoscopy. Okay.
Probably